Hello, and welcome to today's dialogue with Dr. Shinya Yamanaka. My name is Jim Gannon. I'm director of JCIE USA, the Japan Center for International Exchange. JCIE works to build US-Japan cooperation on pressing challenges such as this pandemic. That's why we're so excited about today's discussion. Today's event is co-organized with the Consulate General of Japan in New York, and I want to thank our consulate partners, and especially Ambassador Kanji Yamanouchi, who is going to be giving the closing remarks. We are just honored to have the 2012 Nobel laureate, Dr. Shinya Yamanaka, joining us from Kyoto, and also to have Minister Yasutoshi Nishimura, the minister who oversees Japan's COVID-19 response, joining from Tokyo. As you know, all of our countries have lost people to COVID, and we mourn them. Even one person is too many. But still, Japan's relative success gets less attention than other countries. To date, 1,570 people reported to have died from the disease in Japan, and roughly 82,000 people have been infected. Viewed from where I'm standing in New York City, which alone has suffered 25,000 deaths and where many of us have been sick, including myself, that looks very good. With Minister Nishimura's leadership, Japan took the unique step of standing up an AI advisory board to support its COVID response. Dr. Yamanaka was appointed as founding member of that board, and he's agreed to share some reflections on his work with it. Thank you, Dr. Yamanaka. Today, we've also asked Minister Nishimura to start out with brief remarks. I will then introduce Laurie Garrett, who will preside over the initial session with Dr. Yamanaka and interview him after his presentation. Then we'll open the floor for a dialogue with the nearly 30 prominent experts who are joining us on Zoom. And I think this dialogue will help us identify lessons from our experiences combating the pandemic, and perhaps point to some areas where Japan and the US and others can collaborate more effectively. Before starting though, a few housekeeping notes. First, the experts who are with us on Zoom are currently invisible, but we'll be turning on your cameras about half an hour and giving you prompts to join the dialogue. Also, I should note that we're joined by many more people on YouTube and live stream, and all of you can submit questions for the dialogue too by emailing webinar@jci.org. And finally, we're conducting this as an on-the-record discussion, and we'll make a video publicly available afterwards. So I would like to say a few words about Minister Nishimura before handing him the virtual microphone. I've always been a big admirer of him. He was first elected to the House of Representatives in 2003, and he's now serving his 6th term. He spent much of the past 8 years serving in a variety of cabinet posts in the Abe and Suga administrations, and most recently as Deputy Chief Cabinet Secretary. Nishimura Daijin now wears several hats in the cabinet, including serving as Minister for Economic and Fiscal Policy. He's been in charge of the COVID-19 response from the early days of the pandemic, and that has made his face one of the most recognized in Japan, albeit a face that always has a mask on. Minister Nishimura, please.
Thank you, Mr. Gannon. Good to see you again. Distinguished guests and participants, good morning and good evening. I am Nishimura Yasutoshi, as introduced, the minister in charge of both economic and fiscal policy and novel coronavirus disease control in Japan. I believe there are not so many ministers around the world taking on these two roles at the same time. It's my great honor and privilege to make the opening remarks for this dialogue on harnessing new technology to battle COVID-19 with the renowned Nobel Laureate, Professor Yamanaka Shinya, as the invited speaker. First of all, I'd like to confirm it's important to prevent the spread of COVID-19 while simultaneously sustaining economic activity. In April and May, the COVID-19 pandemic raged in Japan. The government declared a state of emergency and adopted measures such as voluntary business closures to contain the pandemic. We managed to avoid the worst effects of the pandemic without mandatory lockdowns. We employed two techniques, retrospective cluster-based approach and concerted public awareness campaigns to avoid the 3 C's, closed spaces, crowded places, close contact setting, all of which pose a major risk of infection. In July and August, when Japan experienced a rebound in infections, we turned the tide by adopting a focused strategic approach based on our experience in April and May. With genetic analysis, we identified the entertainment districts of big cities as COVID-19 hotspots. These are places such as Kabukicho district of Tokyo. The area is 79 acres. And Minami district of Osaka, the area is 106 acres. The size of each of these districts is about half of the area of Soho neighborhood in Manhattan. We expanded PCR testing capacity in these districts and tested intensively. We also requested the restaurants and bars in these areas to close earlier, and we are able to suppress infections without too large of a toll on economic activity. The most important thing is we should recognize that the virus will not be eradicated immediately. The pandemic will surge again and again. It's unrealistic to make a target of 0 cases. We should instead aim to reduce the number of the cases to a level where it can be contained by adopting effective cluster-based approaches and prevent the development of the most severe symptoms. We are also moving as quickly as possible to develop measures that will be effective in adopting a double epidemic of influenza and COVID-19. In order to do this, I came to the conclusion that it is important to analyze and evaluate the effectiveness of each individual measure taken during the earlier stages of the pandemic based on actual data and AI simulations. I launched the AI advisory board in August to pursue this. Today's speaker, Professor Yamanaka, is a senior member of the AI advisory board. With the recommendation of Professor Yamanaka, we've been trying to develop more effective measures by utilizing the data and the simulation analysis. More precisely, we've been studying which testing strategies are most appropriate and analyzing the efficacy of the measures, such as different limitations on opening hours for shops and restaurants and voluntary restrictions on the movement of people. We all know how potential treatments such as remdesivir and prone positioning can be helpful. And we understand how old age and pre-existing conditions are factors in the severity of COVID-19, but we have also conducted analysis of 5,000 plus cases to find other factors and to identify more effective potential treatments. In addition, we've been developing cutting-edge simulations on the spread of droplets and aerosols by utilizing Fugaku, the fastest supercomputer in the world, which is located at the Riken Center in Kobe. Based on scientific evidence from this, Japan, ahead of the rest of the world, has adjusted limitations on the number of the people at events. For instance, using restrictions on attendance at the events, which are not assumed to have shouts or cheers in loud voices by the audiences, such as movies and classical music concerts, to be held at full capacity, with the outside sports events, such as baseball and soccer games, at half. Japan is moving forward steadily towards the complete recovery of the societal and economic activities while preventing the spread of the virus. I strongly hope that we can work together to better battle this unprecedented global threat by sharing each of our country's experiences and knowledges. Japan is willing to share our experiences with other nations, including the United States. My sincere wish is that, thanks to the contributions of Professor Yamanaka and distinguished guests and participants here today, we can have a fruitful dialogue and helps us meet this global challenge. Thank you very much.
Thank you very much, Minister Nishimura. To start out today, we're asking Laurie Garrett to preside over the initial discussion with Dr. Yamanaka, interviewing him after his presentation. And after that, we're going to have to do some technical tricks and make a transition from an interview to a dialogue in which we have the faces of 30 people visible. So I'll pop up again right before that. Now, just briefly, a few short words on Laurie. Laurie Garrett is one of America's best-known science writers, and she's become one of the most widely admired commentators on the COVID-19 pandemic. She's awarded the Pulitzer Prize for reporting on Ebola in 1996, and she currently is a science contributor on MSNBC and a columnist for Foreign Policy magazine. Thank you very much, Laurie, for joining us tonight.
Konnichiwa. It's my great pleasure to be with you. It's an honor and a privilege. I mean, just being in the presence of Yamanaka-san is an honor and a privilege, even if it's virtual. As has been said, he was a recipient of the 2012 Nobel Prize in Medicine, doing work that he continues to do jointly between the Gladstone Institute at University of California in San Francisco and Kyoto University. It's quite a long commute. But he did something that has had a brilliant impact on stem cell research all over the world, because prior to his breakthroughs, stem cell research was very controversial, very political, because it was thought you had to use fetal cells. And those who opposed abortions would claim that stem cell research was inherently connected somehow to that function, abortions, which they opposed. And by coming up with a method to take mature cells and reverse them, in a sense, back to their pluripotent state so that they could function for research potential and medical potential as stem cells, was an enormous breakthrough, for which I think we all owe Shinya Yamanaka-san a great debt. And we also, I think, owe Japan a debt. Here is a country that has managed to keep its total case number to 84,233 with 1,581 deaths. And most importantly, with a case fatality rate of 1.9%. And in contrast, here in the United States, as of today, we're at 207,465 deaths, 7,263,419 reported cases, and a case fatality rate considerably higher at 2.9%. To put it in deaths per 100,000 terms, Japan has suffered COVID deaths per 100,000 of 1.2, while the United States is at 63.25. It's my honor to turn it over to you, Shinya Yamanaka.
Good evening, everyone. It's a great honor to be here. And it is a really great honor to be introduced by Laurie. I'm so happy. And I also want to thank you, Mr. James Gannon, as well as Ambassador Yamanouchi, for having this great opportunity. Thank you very much. And also for Minister Nishimura for joining us today. So let me share my slide. So as you heard from Laurie, I am a scientist working on stem cells. So I'm not an expert in virology or in any infectious diseases or in public health. But nevertheless, as a scientist in medicine, I really want to contribute to this COVID-19 pandemic. I really want to do whatever I can do to overcome this pandemic. So that's why I'm here today. in addition to my director role in Kyoto, I have a small lab in San Francisco at Gladstone Institute of Cardiovascular Disease. So for the last 13 years, I commute from Kyoto to San Francisco every month. My monthly commute, it takes only 11 hours. But since this February, I haven't been able to visit San Francisco. So that's the effect of this pandemic. So as you all know, COVID-19 or SARS-CoV-2 is really a pandemic. Almost 200 countries all over the world are now suffering from the same virus. It's the same virus. I would say it's nearly identical virus because this is RNA virus. They are constantly changing. So I shouldn't say identical, but it's safe to say they are nearly identical virus. But each country has different policy and strategy. As a result, each country see a different result. This is the point I want to discuss today in this webinar. So Oxford University, they measure the stringency of the policy in each country against COVID-19. This is a time course of the stringency of government response in each country since January. So we have United States, UK, some European country, and Japan. These responses include multiple factors such as school closure, business closure, lockdown, restriction on internal and international trips, and so on. So 100 is the most stringent, strictest, and 0 would be no response at all. So your country, US, is shown here by this color. So since the middle of March, your country, US, has been taking a very stringent response against the virus. It's the same case for UK and other European countries as well, except for Sweden. How about Japan? As you can see here, our strategy has been relatively mild. At the peak in April, the score was only like less than 50. At that time, your score was almost 70 or close to 80. Some country is like almost 90. So I would say our strategy, our policy has been very, very mild. This graph shows the number of PCR tests per capita, per 1,000 people. So again, US has been conducting many tests per capita. So have many other European countries, UK, France, Germany, including Sweden. But as you may be surprised here, the number of tests itself is very, very limited in Japan. Only 0.12 per 1,000 people. But as Minister Nishimura mentioned, we have a very clever test strategy. We target high-risk people only to conduct this limited number of test capacity. Whereas in many countries, including your country, everybody can get tested. Whereas in Japan, only a limited people who are considered to be high risk, they can take tests. That's one of the differences between us and many other countries. So if you think about these mild strategies and limited test capacities in Japan, you may think we should be suffering from this virus very heavily. But surprisingly, that's not the case, as you heard from Mr. Nishimura and Laurie. This is the number of deaths per million people as of September 30th. So many countries suffering from the virus very harshly, including your country. More than 600 people have been killed by the virus per million people. But in Japan, the number is only 12 people per million. So it's only 1/50th compared to many other countries, including US, UK, Italy, and Sweden. It is very surprising. So once again, it's nearly the same virus, but each country is taking different policy and strategy. So in Japan, we have been taking very mild policy, and we only have limited test capacity. Nevertheless, we have observed so far only a few deaths per capita in our country. So there should be some factors that is behind this discrepancy. And no scientists in our country and no scientists all over the world understand what this factor is. So let me call this factor X. There are two important questions about factor X. What is factor X? Of course, this is the most important question. This could be our very smart and focused strategy against the virus. This could be our habit of wearing face masks. As you may know, in February, all face masks disappeared from any shops. I couldn't buy any face masks. Everybody in Japan, even now, even this summer, during a very hot, humid, nearly everyone had masks every day. So that may be one possibility. We may have some pre-existing immunity, weak immunity against this virus, SARS-CoV-2. That's another factor. And there may be some genetic differences between our population and other populations in US and in European countries. But once again, we still don't know what factor X is. The other very important question for us is whether this factor X will continue in the coming flu season, in this fall and winter. That's a very important point. If factor X will continue, we may be okay. But since we don't understand what factor X is, and if they do not continue, we may be in trouble. So we have to see what will happen. And as a scientist, we are doing our best to understand what factor X is. So let me explain what we have been doing to understand what factor X is. So once again, I'm a stem cell scientist. About 12 years ago, we have developed a new stem cell technology, which we designate iPS cells, induced pluripotent stem cells. iPS cells are nearly indistinguishable from ES cells, embryonic stem cells. The only one difference is the source of cells. ES cells are derived from human embryos, which can be problematic in terms of ethical issue, whereas iPS cells are derived from patients' own skin cells or blood cells. So we can convert your skin cells or blood cells, your peripheral blood cells, into ES-like stem cells, which we designated iPS cells. So by taking this strategy, we can overcome the ethical issue of human ES cells. But once established, iPS cells are indistinguishable from ES cells. We can expand iPS cells as much as we want. Then, after expansion, we can convert iPS cells into virtually all types of cells that exist in a body, including neurons, heart cells, muscle cells, hepatic cells, and so on. So for the last 12 years, thanks to a huge and generous support from the Japanese government, we are doing our best to bring this technology to patients in two medical area, including regenerative medicine and also drug development. And now we are utilizing this technology to understand what factor X is. We have been doing multiple strategies, but let me explain just one of them today. So we are making iPS cells from people or healthy people in many countries, including US and Japan. All we need is a small amount of peripheral blood cells, probably just 10 ml. But we can convert their blood cells into iPS cells. Once again, once they become iPS cells, we can expand iPS cells as much as we want. Then we can make from iPS cells lung organoid, kind of mini lung from iPS cells, from people in US, from people in Japan. And we have been testing the effect of the virus SARS-CoV-2 on lung organoid, mini lung, that we generated from people in US and people in Japan. So by doing this comparison, we hope we can understand what's the difference between the two populations. We don't have to do this in the real human. We can do this in Petri dish. That's one of the good points about this iPS cell technology. We can recapturate what's going on in human in Petri dish, in laboratories. So let me finish my talk by showing this slide again. More than 200 countries are suffering from the nearly identical virus. Each country is taking different policy, different strategy, and we are observing different results in each country. My point is, my conclusion, my take-home message is that we should learn from each other. Because of the pandemic, because of the restriction of international travel, I haven't been able to visit San Francisco for the last 7 months. We tend to think our nation only. But this is a pandemic. We really have to think globally. We have to learn from each other. And I believe that's the best way to overcome, to fight against this virus. And that's what I really want to do, want to continue to contribute to this pandemic situation. Thank you very much.
Thank you. Perhaps you can stop your sharing function with your slide. Thank you very much.
I think I did.
I have a couple of quick questions for you. Our time is short. But in terms of getting to this factor X and trying to imagine what might be some of the issues going on there, it's worth thinking about that. All of the countries that experienced the 2003 SARS epidemic have done very well, with the exception, of course, of China. They've kept their numbers down. And even when it looked like things were going to go bad, such as occurred in Singapore, they managed to bring it back down very quickly. What do you think is the most significant aspect of that 2003 experience that has informed the response capacity in these key Asian countries?
Yeah, SARS and MERS, those two examples really worked in those countries. But Japan did not go through those two previous coronaviruses, fortunately or unfortunately.
You went through being scared to death of them.
So those countries who did go through those two previous coronaviruses, I believe they were well prepared, like PCR testing, contact tracing, and most importantly, mindset, I believe. So like in Japan, infected people tend to hide they are being infected because they may be attacked by other people. Whereas I heard in Taiwan, the first patient who suffered from this SARS-CoV-2, he was actually on the airplane. He was flying back from somewhere to Taiwan. And he noticed he had a fever. And I heard he raised his hand and please isolate me. That's what he mentioned, to protect Taiwan, the whole nation. So that's kind of a mindset is really, very important. And also those countries has, like countries like Korea, they have a high capacity to conduct PCR testing from the beginning. So those are really actually an advantage, I agree.
I think another big lesson from SARS 2003 is that was really a nosocomial disease. It spread inside hospitals.
Yes.
And all of those countries really improved their infection control standards after 2003.
Exactly, I agree. So they learned very important lessons from those experiences. And that's what we should do. We means US and Japan. We should do from this pandemic. Mm-hmm. First of all, we need to overcome this pandemic. That's the highest priority. But in addition to that, we should learn from this pandemic. Most likely, we will have another pandemic in 10 years, 20 years, 30 years. And we don't want to repeat. We don't want to repeat the same thing.
Yeah.
We really need to learn.
Let me ask you another wild idea for Factor X.
Yes.
When this epidemic first appeared in Wuhan, because the key presentation for acute care was pneumonia, everybody thought of it as a respiratory disease. But increasingly, as we see the cells that present with ACE2 receptors, it's becoming clear this is a cardiovascular disease, and that a lot of the long-term effects in survivors are associated with cardiovascular difficulties. And we had this recent, very bold publication based on microscopy, showing that the virus really denucleates, infects and denucleates the heart muscle cells.
Yeah.
And that made me think, okay, first of all, Japanese eat lots of fish. You tend to have fewer people with high blood pressure, fewer people with high cholesterol counts, fewer people with underlying cardiovascular problems compared certainly to the United States and the UK, where we have obesity issues and lots of high blood pressure issues and untreated cardiovascular, the sort of silent killer classic problem. And then you also, because you eat a lot of fish, you have a protective effect from the fish itself. So I wonder if the factor X might actually be in some way connected to a cardiovascular. And then part two of that would be, could stem cells be used to deal with these long-term illness problems by replacing some of the destroyed cells of the cardiovascular system?
Yes. Yeah, that's another very important point. Once again, I belong to Gladstone Institute of Cardiovascular Disease. And we are making heart cells from iPS cells as well as ES cells. And my colleagues have been testing whether this virus, SARS-CoV-2, can infect heart cells. And they do. They do more than probably lung cells. So in many countries, in US and in Germany, now many scientists do believe that this is not simply a pulmonary disease. This is a cardiovascular disease. And many recovered people, they suffer from heart dysfunction. But another important issue is it's not so obvious in Japan. I have been talking to many Japanese doctors who have been treating COVID-19. They don't see a strong effect on their heart function in their Japanese patients. So this is where some big difference may exist between Japanese people and many other countries like US and Europe. So we also want to study this potential difference. We can make heart cells from iPS cells from US people and iPS cells from Japanese people. And we are now doing infection of this virus to heart cells from stem cells. We may see some difference. Maybe ACE2 receptor you just mentioned. ACE2 is like an entry point of this virus to human cells. So maybe the number of this entrance ACE2 receptor is different between populations. That's why the virus do not affect Japanese heart, maybe. So that's one important issue too. That's a good candidate of factor X.
I think we're going to have to switch over now back to James Gannon because our time is running short. Thank you so very much.
Thank you very much, Laurie. Thank you. Thank you. Yeah, I hope to see you in person.
Yes, soon.
Yes, very soon.
Thank you very much, Yamanaka Sensei and Laurie. So we're going to start turning on the cameras of all the dialogue participants. This is going to take a minute or two to have everybody on board with us, so please bear with us. And so those of you who are on Zoom or in the dialogue, you're going to need to do a couple of things. First, you're going to get a prompt to join as a panelist. Please click yes. Then second, you may also get a prompt to turn on your camera, and please click yes for that. And if you don't see your face on the screen, in the bottom left-hand corner, you have the icon of the camera. If you just press that. Here we go. So while this transition is going on, I want to thank all of you who are watching on YouTube. And I want to note that you can also send questions in to us. And to do this, you just have to email them to webinar@jcie.org. So we'll be waiting for those questions. I'm just going to wait a little bit more to see a few more faces pop up here. Very good. Now that most of you in the dialogue are back with us, just please let me explain for a minute how to make comments and how to ask questions. So I'm going to be moderating, and I can't see everybody at once here. So I'll ask, there's a raise the hand function. And to do this, you'll see in the bottom of your screen in the middle there, there's a participants. And if you click on participants, a box is going to pop up on the right-hand side. And then in that box, there's a raise hand. And if you click on that, you raise your hand. I'll keep track of you and try to recognize as many people as possible to speak. And sometimes when you speak, you're going to, the view sometimes changes there. So if all of a sudden you're always seeing your own face, then you can go back and click gallery view in the corner to get back into seeing this grid. Finally, when you're recognized to speak, you're probably going to need to turn your microphone on. And if you could turn that off when you're done, and if not, our IT consultants may do that for you. One other point here, we're running a little bit late. So with the permission of the panelists, I would like to end not at 8:15, at 8:20. But if people need to get off early, we'll understand that. Finally, well, Dr. Yamanaka has a really extraordinary mind. As he said, he's not an epidemiologist, not an AI expert, but fortunately, we're being joined from a few such experts from the Cabinet Secretary to Japan. One of them actually is Dr. Hajime Inoue, an epidemiologist from the Office for Novel Coronavirus Disease Control. And they can respond to comments if Dr. Yamanaka wishes as well. So with that, let's go. First, I really want to recognize a real leader in the United States, Dr. Victor Zhao, who's the president of the National Academy of Medicine. Please, Victor.
Oh, thank you. Shinya, it's really great to see you. And actually, you brought out all my friends on the screen. I haven't seen Ariel, a number of others for a while, so it's wonderful. Thank you very much for a very stimulating talk and to create this dialogue between US and Japan. So as you know, I'm a cardiovascular researcher, so I will keep those questions to cardiovascular. First of all, as far as ACE2 receptors, I think they're densely populating endothelial cells. So the cardiovascular disease is really endothelial damage, and therefore vascular damage, which lead to many of the thrombosis valve disease that we see. That's my comment. But I think the issue of using iPS cells is very interesting because, as you know, in our country, we see a disproportionate effect on African-American, Hispanic, and communities of color. And so the question related to your studies are the following. One is, of course, are these cells derived from what's an American? I'm an American and I'm not white. So actually there's a lot of these diversity issue that needs to be addressed in terms of the cells that you study and the population study. At the National Academies, we are releasing a report tomorrow related to vaccine allocation. And our debate was whether it's skin color or biology or is it social effects that is increasing vulnerability. And we actually concluded that it is more related to social vulnerability than the biology itself. So therefore, we are looking at those social indices that predicts more vulnerability, such as crowded living, comorbid diseases, the kind of work you do, poverty, and so on and so forth. So it's interesting that you would propose a biology basis where I think it's, at least in our world, is somewhat controversial. And we believe it's more social than biology. Thank you.
Well, it's so nice to see you, Victor. I didn't expect. So I actually agree. I can't agree more, actually. I think biology or genetic background may be important, but I think social issue you just mentioned is probably far more important. But in addition to that kind of social or component, there may be some genetic or biology background. So that's what I want to figure it out, because I'm a biologist, I'm a scientist.
Yes.
But for example, not only Japanese people, but Asian people in general, we less number of deaths per capita in general. But your country, New York, San Francisco, there are many Asian people living there. The number of deaths, yes, including you, and the number of deaths per capita is not so small for those Asian people in US. So that alone clearly show that the primary cause is not a genetic difference. It's more like social or environment or maybe food, something like that. But in addition to that, I believe there may be some genetic factor. So yeah, that's my point.
Thank you.
Thank you.
Thank you very much. And next I'll ask Ambassador Mark Deibel, who's the former head of the Global Fund to fight AIDS, TB, and malaria. Mark?
Thank you, James. And Yamanaka-san, unfortunately, we've not met, but good to see lots of other people, including Victor. I haven't seen in a while either in Japan and here in the United States. Picking up on Victor's question, I mean, structural issues, systemic racism and other things are definitely issues, as Victor pointed out. But I think we can explain 90% of the difference in most countries by good policies and bad policies and good response and bad response. And the reality is the United States has had among the most appallingly poor responses in the world, sadly. And we know from New York and other places that those policies affect us. The death rate in hospitals that were way overcrowded were very different than hospitals that didn't at the same time. So we can explain a lot of that, but I think what you're getting at is once we clear that noise out, which hopefully we will soon, then what are causing the not only deaths, but susceptibility to disease, which I think would be interesting as well, not just the fatality, why are people dying disproportionately, but also why are some people getting infected and not, or not. And I wanted to ask you about a couple of things that have come up and your thoughts on them from other people's work. Using artificial intelligence, for example, bradykinin, and bradykinin, of course, is a problem in African Americans. It leads to a disease that looks a little bit like some of the side effects we're seeing, cardiovascular side effects we're seeing in African Americans. Interferon receptors already identified potentially as a key factor. So I'm wondering your thoughts on those, and if some of your research now is pivoting to follow some of those models or look at them, because I think what you're doing is very important, especially in subpopulations, for example, children, which we have no idea really what's going on with kids. And if you're now moving from the general populations to some of these subpopulations along the lines of Victor's question, but with a slightly different angle. Thank you very much.
Yeah, it's a very important point. Thank you very much for asking. So even after getting rid of those social and non-biological backgrounds, we may see differences between the country, between the populations. For example, I believe San Francisco has been doing very well. They have one of the best medical system in the world. And all of my friends and all of my colleagues in San Francisco, they wear masks. They take social distance. And so as a result, I believe they have the lowest death number among the rest of major US cities, including New York, Los Angeles. So San Francisco is doing very well. And they behave very well. All the restaurants are still closed, at least inside is still closed. But nevertheless, the number of deaths in Osaka, in Kyoto, in Tokyo is much smaller than in San Francisco. So if we compare like Osaka, Kyoto, and New York, we have to consider many non-biological issues. But if you compare San Francisco and say like Osaka, I think it's a good model to understand what's going on between the two populations. And because I have a position in Kyoto and in San Francisco, I have been thinking what I can do to compare those two populations. So I hope I can, I just answered to at least some of your questions. And in addition to pulmonary effect and cardiovascular effect, it's a immunological kind of disease. So immune response to the virus may be very different between people in San Francisco and people in Japan. So that's what I want to explore as well.
Thank you. And next on queue is Dr. Carroll, Dr. Dennis Carroll, formerly USAID. Now he's championing a global Virome project. Please, Dr. Carroll, and you have to take mute off.
Great. Thank you, James. Dr. Yamanaka, thank you. Really interesting presentation. The success that you've shown a light on in terms of Japan, we've seen similar profiles in Thailand, Vietnam, South Korea. And I would, both in terms of the numbers of people infected and the mortality rates. And when you think about factor X, I was wondering how you might sort of extrapolate from your experiences in Japan and look at your neighboring countries, particularly in light of the graphic that you showed in terms of Europe and the United States or North America. Profound differences in terms of how the virus is spread and the clinical implications of that virus. And again, Asia or Southeast and East Asia have really stood out in a profoundly different way than the rest of the world. And I'd really be interested in your thoughts, both in terms of transmission, the initial infectivity, but also the clinical consequences of the virus. Thank you very much.
Thank you very much. That's also a very important point. I believe factor X is not a single factor. There should be multiple factors. And I guess some of them are common among Asian countries. So some of them are common between Japan and South Korea, but some unique factor also exist, I believe. So the common factor may be wearing masks in our neighborhood. It's common in many Asian countries, including Japan and Korea. Just 6 months ago, or scientists, including me, do not believe that masks would help because virus can go through masks. But now the concept is totally different. The mask does prevent virus. Virus, not virus itself, but the exposure of the virus, droplet. So wearing the mask from the beginning, from early January, is maybe very important. But policies are different in each Asian countries. For example, test capacity has been very high in South Korea from the beginning. They have been testing almost everyone. So they set up a so-called drive-through testing facility for the first time in the world, I believe. So, and they have a very strict contact tracing system utilizing GPS, and it's not the case in Japan. So that factor is working very well in Korea, but not in Japan. So even among Asian countries, there are many differences. So we still need to learn from each other.
Thank you. And I'm going to jump in and quickly, I was going to go to Dr. Robert Yanagisawa, who has actually been dealing firsthand with many COVID patients at Mount Sinai Hospital. But before that, I just want to say a special thanks to Laurie, Garrett. I know you have to be on a television show in 5 minutes, so you'll leave us, but we appreciate what you were doing.
Thank you. Thank you,
Robert, can I hand off to you, please?
Yes, thank you very much, Dr. Yamanaka and James and everyone else. I think it sounds wonderful. As many of you have mentioned, this COVID seems to be really a multi-organ disease, not only affecting lungs, but obviously, people get strokes, people get heart attacks, people, as a lot of a team of multi-specialty subspecialists who are all involved in COVID care in New York in late March to April, and all of us were quite stunned how much extent of disease was affecting how much multi-organ were affected by the disease. So if we take the, proposed like social effect, the genetic effect, which type of a viral types that patient may be affected, include that on top of their clinical findings and the laboratory findings, perhaps include, if let's say AI could take all that into account and then give us frontline clinicians what may be, this person might fall into kidney failure, so watch out, or this person's going to have a stroke, so treat that. If those perhaps even suggestions could be given, I think use of your genetic data and all the data that's coming from all over the world, it's coming too fast at the rate for the frontline workers to be able to understand this, comprehend this, and then read about it, and then apply to clinical outcome. So if AI could help that, that would, I think, amazingly propel our ways to care for these patients. And I wondered if you had some thoughts about that, Dr. Yamanaka.
Yes, thank you very much, Robert. First of all, I have to say, Robert is my personal, or kind of my personal physician. He rescued my life. It was like 5 years ago when I was in New York and I suffered from a severe toxic food toxicity, and he rescued my life. So thank you so much. I owe you a lot. Regarding your question, I think it's very important. I'm a member of SAB board of AI activity in Japan. But so far, I believe our activity in Japan do not consider that point, patients' outcomes. So I really want to propose that activity as well. The number of patients, especially number of severe cases, kind of limited in Japan. So here, international collaboration is essential. Fortunately or unfortunately, the number of severe cases suffering from multi-organ systems is not so high in Japan. So we really need to, I believe, collaboration. But that's a very important point. Thank you very much, Robert.
No, thank you.
Thank you very much. I was going to pivot a little bit to the discussion of US-Japan collaboration. And actually, Dr. Kilmarks with the Fogarty Center is with us. I was going to hand off to him, but I just wanted to just repeat, because I know this, I said this while people were still coming on. If you have questions, you can use the participant button on the bottom. You click that, and then the bar should pop up, and then you use the raise your hand function, the bottom right-hand corner, and then to flag if you want to be asking a question here. So with that, Dr. Kilmarks, please.
Hi, thanks, James. I'm really honored to be part of this very distinguished group. Just on the previous topic, I think I may be more in the Mark Deibel school, that it seems to be more the public health response and epidemiology, noting that in Wuhan, clearly in Asian populations, it's able to be a very high rate of transmission. And then just noting the contrast, the very high risk for Black Americans in the US and relatively lower transmission in Africa. So it seems to be more of a social structure, epidemiology, public health response factors than genetic perhaps, but certainly we need to explore all aspects of this. But James, thank you. I did want to pivot to, as you're saying,
talking about the potential, the actually already ongoing extensive US-Japanese collaboration and the potential for extending that. So I'm at the Fogarty International Center at the NIH. We support all of the NIH in the international collaborations. And I just wanted to make three quick points. One is that there's already very extensive collaboration between the US and Japanese researchers supported by NIH. There's just in the last year, there's 487 active collaborations with 387 investigators and 184 organizations. And this is with almost every NIH institute, the National Institute of General Medical Sciences, National Cancer Institute, National Heart, Lung and Blood Institute, okay, I'm going off. AID. So, really a very active existing set of collaborations. There's 134 Japanese postdocs at the NIH currently. So a lot of many prominent scientists Japanese scientists have had experience in training and relationships at NIH. There's also multiple formal collaborations between the US and Japan. There's the US-Japan Cooperative Medical Sciences Program. There's the Japan Society for Promotion of Science that sponsors fellows coming to NIH. There's the Japan Agency for Medical Research and Development that has an MOU with NIH. So quite extensive there. And then there is already ongoing COVID-19 collaboration through these established mechanisms and relationships. There's been the National Center for Global Health and Medicine in Japan is part of the adaptive COVID-19 treatment trials, enrolling in the number 1, number 2, and number 3 of those. So looking at monoclonal antibodies, looking at hyperimmune intravenous immunoglobulin. So these are already active collaborations enrolling study participants in the US and Japan. And then lastly, that there's been extensive support and interest from the NIH in artificial intelligence. There's tens of thousands of publications on AI supported by the NIH. Almost every grant-making institute at NIH is funding this. It's really been an explosion of interest and activity with the National Library of Medicine is investing $500 million, NCI $400 million, and 8 other institutes investing over $100 million in AI. So this is a very ripe area, and I think should definitely be further explored, and happy to follow up in these discussions on these Japan-US collaborations on COVID-19 and AI in particular. Thanks.
Wow, thank you so much for supporting the collaboration between the two countries. I hope you will support me as well.
Thank you. I wanted to push a little more on the US-Japan piece, and one of the most prominent Washington experts on US-Japan, I should say not a health expert, but a prominent expert in US-Japan, Dr. Sheila Smith's with us. And if I could just put you on the spot, Sheila.
Thank you, Jim. Professor Yamanaka, I am delighted to be able to join you tonight, and Consul General Yamanouchi, thank you also for including me. It's just a real privilege to be able to hear your thoughts on where we are today with COVID-19. As Jim introduced me, I am not a scientist by any means. I'm not a public health professional either, but one of the things that I think is so valuable to the United States and Japan, as Dr. Kilmarks amply demonstrated here, is the capacity of our two people, our scientists, our public policymakers, and of course our political leaders, is to come together to try to help to solve global problems. I sit in Washington, D.C. I'm a little worried about our capacity to come together with other countries around the globe. I do think the US-Japan partnership is a really good catalyst for a global conversation, but I wanted to seek you out a little bit, again, as a non-scientist, on where you think people like me at the Council on Foreign Relations, who are in the public policy domain, might be able to support those of you who are in the more scientific side of the problem solving, and how perhaps you could comment a little bit more on where you see the United States and Japan as having opportunities for a broader global conversation on some of the issues you're talking about. So help us understand how we can help you, I guess is my first question. And second, how do we build bridges to a global community, which right now the WHO and other institutions, of course, the United States is somewhat critical of, to be quite frank. So we have to think about ways to building bridges, I think, in the public policy realm.
Yeah, so COVID-19 is a virus. It's a threat to our health, our life, but it's also a huge threat to our economy.
Right.
So it's kind of very unique virus. Like influenza, it's a threat to our health, but not to our economy. So for the first time in the last 100 years, this virus is a threat, not only to our life, health, but also to our economy. So people like you and people like Minister Nishimura is having a very hard time in between life and economy. So as a scientist, we have to, all we can do is do the best science. But sometimes I feel like sometimes it's difficult to speak up about our scientific result because it may affect economy in not welcome way. So I hope non-influential people, but non-scientist people like you will support us to freely speak up.
Right.
Yeah, from a scientific point of view. I think we have to be very brave as well.
Right.
Because we may be attacked by some other people, sometimes by TV. But as a scientist, we need to show what we observed, what we learn from data. So I think that's probably one of the most important issues in this unprecedented scenario right now.
Thank you. Thank you very much.
Thank you. Thank you.
We'll do what we can.
Thank you very much. And I'm going to just take the chair's prerogative here. But before doing that, I just want to mention that we'll do just one more round of questions. So if anybody has burning ones, that's your last chance to get them in. But I would love to hear if and just from a generalist standpoint, if there are ideas and schemes that you've seen coming in front of the AI Advisory Board with real practical applications that the United States really should be emulating at this point or thinking about. Thank you.
Yeah, it's very important. Yes.
Oh, and I'm just wondering if you could offer suggestions or one or two of those schemes, if there's things that us in the United States should be looking at Japan for that the AI Advisory Board is considering at this point.
So far, all of AI advisory board on this activity, Japanese scientists. We really need to have input from outside, from people in US. So even for this kind of SAB activity, I really believe we should make it more international. So AI experts in US, you have much more AI experts in US than in Japan. So I hope some of those AI experts in US can be involved.
I do hope that there is a scheme to collaborate. Maybe we could even do a follow-up dialogue or two to talk about that. I wanted to hand off finally to another doctor at Mount Sinai, Florian Kramer, and he actually invented the antibody test that I've been using and benefiting from. So I actually owe him, he doesn't know this, a bit of thanks. Florian, please.
Yes, thanks for the introduction. So I wanted to make a comment about AI and more about the future, not about the current situation. So, you know, we have these issues with zoonotic infections and zoonotic viruses now for a long time, right? We had 4 flu pandemics in the last 100 years. Now we have SARS-CoV-2, but we also had SARS-CoV-1 and MERS before. And maybe on an international level, AI could play a role in predicting better where these things happen and when they might happen by looking at things like population density, trade, zoonotic or circulation of these viruses in different animals, and so on and so forth. Of course, that would require very strong international collaboration, a very strong exchange of data, and probably a global network that can do that. But since this is really something that we cannot predict based on simple models, I think AI could play a very strong role to circumvent a similar situation in the future. And, you know, we know that these viruses will keep coming. It's not that this is now a pandemic and then the pandemic is over and we'll never be in that situation anymore. We probably get more of them just because there's more interaction with wild animals.
Yes, I can't agree more. You know, as a scientist, we have to be more, I guess, what's the best terminology? We have to be more humble, probably. Because in this, just 6 months ago, in February, no scientists, I have to say only a few scientists were able to predict what would happen in the next 6 months. Once again, in February, when I visited San Francisco or last time, this year, I met some of my virology friends, and they said, well, COVID-19, at that time, it was not named SARS-CoV-2. It has novel coronavirus 2019 or something like that. The consensus was we have to keep an eye on it, but influenza is more a threat to people in US, people in Japan. So nobody were able to predict this scenario, this pandemic. So we have to be, we shouldn't forget that kind of limitation of us scientists. So we really should learn from this tough experience to set up an AI program to predict this kind of scenario. It's only like 6 months, or you know, in March, in the middle of March, a burst took place in US and in European countries, and we did not, we couldn't predict what would happen in the next 4 weeks. So we have to stop this limitation, and we have to fully utilize AI to learn from what we just experienced. I think it's what we really have to do.
Dr. Yamanaka, thank you. We're praying for your success. I'm going to hand off to Ambassador Yamanouchi here to close us, and thank everybody for staying on a little late too. This has been a great discussion. Ambassador Yamanouchi.
Thank you, Jim. Thank you very much for all the participants. I don't know how to say thank you. My thank you is not strong enough to express my gratitude to everyone. And tonight's event, I really wish we had more time to listen to all the views and ideas from the very scientific view to the US-Japan relations and the cooperation. This is an amazing event online. So first of all, I would like to express my gratitude to Yamanaka sensei. Thank you very much. I know you are very, very busy. Only Zoom meeting is possible for us to have you here. And also, I would like to thank you, Laurie Garrett. She left for NBC, but her question was very inspiring and insightful. So it's amazing. And also to Jim, I remember my conversation with you about 3 months ago over Zoom meeting. By mentioning some kind of US-Japan relations and the cooperation on something about COVID-19. And American people do not know much about how Japan fight against COVID-19 things. Then, Jim, it's you who started these things after 3 months. So thank you very much. I've heard preparation was never easy, but you and your leadership and your staff did a great job. And also, Minister Nishimura, and also Takemi Sensei participated from Tokyo. Zoom is great. We can easily overcome the time difference and the geographical distances. And also, Dr. Kilmarks, you mentioned NIH. Up until 4 years ago, I lived in Washington. I was with the Japanese embassy, and my residence was only 10 minutes drive from NIH. So it's very amazing. So many cooperations going on between Japanese and American scientists. And this is great news for diplomats from Japan. And COVID-19 is not end. We as a world are still in this difficult situation. But I couldn't agree more. I couldn't agree more with Yamanaka sensei. Cooperation and learning each other is so important, especially Japan and the United States. We could do more to help people in need, not in our two countries, but in the international communities. So this tonight's webinar is a very important starting point for that. So once again, thank you very much for all the participants.
Thanks to Jim and thanks to JCIE.
So CiRA,